All right, thank you very much. I would like to explain a little bit about a safe atherectomy system that has been developed by Avenger. It uses an OCT imaging system which is built into the atherectomy cutters. And by this you can, for the first time, see from inside the vessel and treat the lesions safely without injuring the vessel wall. And you can see here on this very first image what the OCT looks like. It shows you on the right-hand side over here the media, which is this dark area, followed by a white line in the back, which is the media adventitial border. And you can direct this cutter of the device 360 degrees to target plaque in a lesion. It's the 𝗙𝗏𝗄𝗃 catheter, and this is an animation to show you how this works. So you bring in a 𝗍14 wire over which this catheter can be deployed. When you open it, it will be pushed up with a balloon, and by moving it forward, it actually captures the plaque. Very similar, you might know the Hawk devices. It does a very similar function, but here with the imaging. And the imaging, which is animated in the bottom here, shows you where your border to the vessel wall is. So you can decide on how many cuts and in which direction you want to do them without touching the media of the patient. This device is suitable for below the knees vessels. We have a 6 French sheath compatible one that goes all the way down to the foot, and there is a larger one which is usually used in the SFA that goes up to 7 millimeter vessel size compatible with a 7 French sheath. This again is a screenshot of what you see. When you see white areas in your imaging, you know that this is the disease, and clearly visible behind the white is the dark area, very well structured, which is the vessel wall. And that imaging system sits inside the cutter. So you are only 1.2 millimeters away from where you are actually cutting. So that's the advantage. This is the real life video of it to show how it's done. The markers here show you which way you are pointing. We are now looking at 6 o'clock, and the physician is rotating the cutter. It's looking around. We can see the vessel wall here, and by now pushing towards the distal direction, shaving off the plaque, and you will now see how the vessel wall actually gets closer and closer to the cutter. And when we reach that vessel wall, we stop, we close it. The image becomes blurry because the cutter is inside the safe housing. And this way it gives you the opportunity to be very accurate and very safe inside an artery. There are some case samples here. These are images of pre and post treatment and without using a balloon afterwards, cleaning out an area here. Here, this was a CTO that was crossed with a wire first, and then atherectomy performed also without the use of a balloon afterwards. You can, it's of course your free choice to use a balloon in these cases, which was done here. Many times a drug-coated balloon at the end is followed the atherectomy. Another, and I find really interesting opportunity for this technology is to treat in-stent restenosis. And this is due to the reason that the stent struts, which you see here as a dotted line, are clearly visible when you treat the occluded stent. So instead of now watching out for the vessel wall, you just look out for these struts here, and you can advance your cutter, removing all this tissue that has grown into the stent and getting much better blood flow established. And this is another display on how this works the system is inside the stent, the struts are clearly visible, and when these struts get too close to the cutter, you simply stop the procedure at this point. 𝗂𝗏𝗀𝗃 has done a clinical study with 20 centers internationally around this and compared the data, and it came out to be a very favorable results. After 1 year with Pantheris, 89% of the lesions were free of re-intervention, and when you compare that to other data that is available with, for example, laser atherectomy or just balloon treatment, these are much, much better outcomes. This is what we retrieve. It is collected in the nose cone of the catheter, and you can remove it from the catheter, use it either for histology or other ideas. A second device that I wanted to draw your attention to is a also OCT guided device. It's called 𝗖𝗇, and it is used for CTO crossing. So sometimes there's longer CTOs that might be very challenging to cross with a wire, or they might need a lot of radiation to cross, radiation time, and there is a device that works without a wire. It has this detailed tip that is a drill type rotating tip, and so if the wire stops here at a totally occluded vessel, you do the same thing that you would do with the atherectomy device. You can orient this in 360 degrees with a marker system, and whenever you get close to the vessel wall here, you reorient the catheter, and because it has a kink at the tip, it will follow a different direction. It carries an 014 wire with it along inside the catheter that you can choose the wire that you would like. And once you reach to the distal cap, the device will have created a channel, and you can now deploy that wire and have all the options that we know for over-the-wire treatment, from atherectomy to stent to ballooning. And this is an interesting option when CTO crossing without a wire, luminal CTO crossing is the goal. Same system here, 3 markers, 360 degrees. You see the media on the OCT here, and you can direct your device away from it. Yeah, this is the last slide and video about a 300 millimeter situation of a total occlusion. Proximal cap, distal cap, you all know these cases, very classic standard situation. And so the 𝗖𝗇 is deployed here on the right side. The little stem gives us a good starting point on the OCT. We can see what's around us. There's a dissection here visible that was from testing the wire in the initiation of that procedure. And the physician is pushing forward the catheter and is watching out for the vessel wall, which is shown here again. And he now needs to turn it, put the middle marker over the vessel wall, because that will make it steer away, like he did here. And then continue down through the artery. And this is a device that 𝗂𝗏𝗀𝗃 also is developing for the coronary space, where this might also be very interesting to cross CTOs that are challenging to cross with wires. You can see how you slowly advance. But in this kind of a case, a 300 millimeter CTO was crossed within 10-15 minutes of time, which can often be much, much longer, and this provides the advantage here of doing this in the lumen and to avoid subintimal crossing. All right, thank you very much.